Bueno, creo que ya vamos a comenzar.
We would like to thank to all the people who have connected over the internet. People from Michoacán, Apatzingan, from Hospital Zaragoza, from Tepic, Nayarit, Centiste, Medicina del Trabajo, General Hospital, from the Clinic Morelia, people from Querétaro, Regional Hospital in Monterrey, Mexico City, Huejutla, Hidalgo, the Eastern units in Oaxaca and Tultitlán and Peru on high specialty hospital in Veracruz. Also from Girona, España, from Spain, thank you. East Tehuantepec. And special thanks for all the people who have connected and have followed this transmission on the internet. So the floor is yours, Alan. Thank you, Ulysses. Thank you. It is my pleasure to start with the next part of the agenda, where we're going to be talking about training. And I think that this is one of the most important parts of this debate, of this exchange on the public policies on the care, because as we have heard from several people, specifically from the panelists in the morning, if we are going to have 20 million new workers in the care system, we know that most of those people will be women. And if we don't have a policy to make this as formal as possible, we know that the work that is going to grow the most at a global level in the next 10 years is going to be work without access to social benefits, without access to health in many countries. And we are leaving these 20 million people, which most of them are going to be women, we are tying them to poverty. So we need to think, we need to come with new ideas and to implement new systems, new care systems to avoid this situation. Because at some point, the people who takes care of the people who are starting this career now, in 10, 20, 30, 40 years, they will age. And then we're going to listen to our panelists from our brothers and sisters on the table. No, not that video. That video, we're going to watch it later, when the people from the Dominican Republic take the floor. I'm sorry. That sounds like issues with the video. La mayoría de los trabajadores en Brasil son de sexo femenino. We don't have social benefits or training. It leads to high turnover.
envejecen rápidamente y aumentan las horas laborales del sector. Cada vez más personas y trabajadores tienen que ser reconocidos y recompensados para brindar servicios confiables y garantizar una vida saludable a quienes cuidamos de la sociedad. La voz de las trabajadoras es importante para construir sistemas de cuidados integrados que ayuden a reducir la carga de cuidados que recaen sobre las mujeres en sus hogares y también valoren la contribución de estas trabajadoras en nuestra sociedad.
Sabemos que hay una relación directa entre las condiciones laborales de estas trabajadoras y trabajadores con la calidad de atención de los cuidados. A más formación y más formalización, mejor es la atención. El éxito de la prestación del servicio de calidad requiere que estas trabajadoras y trabajadores estén en el centro de cualquier infraestructura de la economía del cuidado.
Es muy difícil la responsabilidad de los cuidados recae. Sé que somos muchas las mujeres que cuidamos a nuestros familiares en casa. Mi sueño sería poder contar con protección social y tener una remuneración por lo que hago. Como cuidadora 20 anos y es muy complejo.
Si el cuidado dura durante 20 años, necesito tener una capacitación y considero que es necesario alzar la voz de forma colectiva para defender nuestros derechos.
Propiciando con el respaldo de fondos públicos un sistema nacional de cuidado para enfrentar a estos cambios y reducir el trabajo de cuidado no remunerado. Es importante que estos trabajos que se crean a partir de estos sistemas sean con acceso a un seguro social, a formación y a la posibilidad de tener una fuerte voz colectiva para las y los cuidadores.
Cuido a él de 80 años y a través del programa estatal Medicaid tengo un trabajo formal con mejores salarios, seguro de salud y seguro para el retiro. Para las personas trabajadoras de este año 705 también fue clave los entrenamientos que logramos a través de la Unión para ayudarnos a cuidar de una mejor manera y lograr una mejor recompensa a nuestra profesión. Ser parte de la Unión como lo ha hecho hace 18 años fue clave para lograr las condiciones laborales con las que miles de personas trabajadoras en el estado de Washington estamos hoy en día.
Estamos tejiendo alianzas entre los sindicatos y actuando junto a las organizaciones gubernamentales y los gobiernos para desarrollar el sistema de atención domiciliaria para brindar la mejor calidad de atención y cuidados a las personas mayores, a los niños y a los adultos con diversidad funcional.
Desde la República Dominicana, nuestra organización FENAMUCRA, a través de su centro de capacitación, ha estado firmando un convenio de colaboración con el gobierno. Este persigue formalizar y dotar en competencias técnicas al personal que ellos contratan para dar servicios en los domicilios. Uno de los objetivos que también tenemos como organización es el de visibilizar ante la sociedad por la precariedad que muchos de esos cuidadores y cuidadoras ejercen su trabajo. Este es un valor incalculable, un trabajo trascendental para todo el Producto Interno Bruto del país. Debería de tener derechos como cualquier otro.
Com algumas pessoas que têm uma organização de cuidadores para auxiliar na discussão sobre política nacional de cuidados.
Queremos organizaciones que garanticen humanizar, organizar y formar a las trabajadores, lograr un sistema nacional de cuidado que responda efectivamente a la realidad para vivir en el mundo hoy. Un sistema regulado en torno a la capacitación y la calidad, la promoción de la equidad de género y la reducción de la desigualdad y organización con sindicatos que tengan acceso a la negociación de derechos. Nuestras afiliadas, Brasil, Colombia, República Dominicana, entre otros países, están liderando el camino y sentando la base para lograr un sistema de cuidados que cuide a quienes necesitan.
Las mujeres hemos demostrado nuestra capacidad de valorar y estamos ansiosas de seguir ganando para las trabajadoras del sector de los cuidados.
Bueno,
Now I'm going to switch into English. Muy bien, quiero darle la bienvenida al panel, a Kathy Leach y a Mariana Morante. Ellas forman parte de CU 775 y van a compartir con nosotros las experiencias que han tenido en el desarrollo de un sistema de cuidados en el estado de Washington en los Estados Unidos. Adelante. Micrófono suyo. Muy buenas tardes. Para mí es sumamente emocionante el estar siendo invitada a esta conferencia. No solo se trata de una invitación especial para mí, sino que ciertamente es increíble escuchar las pláticas que hemos tenido, el intercambio que hemos tenido con nuestros colegas y cómo han estado trabajando con sus sistemas de cuidado nacionales. Nosotros buscamos realmente tener ciertamente hay proyecciones y hemos estado hablando de las proyecciones del número de gente que es creciente, que va a ir necesitando de nuestros servicios y cómo vamos a ir incrementando los servicios y protegiéndonos al mismo tiempo. Probablemente en este punto ya sepan que en los Estados Unidos no tenemos un sistema nacional de cuidados. Los servicios que se encuentran disponibles a nivel institucional en las comunidades. Ay, perdón, no puse la presentación. Ay, me pasé. Muy bien. Nuestro financiamiento con fondos federales y estatales es a través de Medicare. Y esto es para individuos. Y bueno, cuando menciono un sistema a largo plazo de cuidados en Washington, es uno de 50 estados y esto difiere entre estados. Cada uno tiene su programa y es muy distinto. Hay algunos estados en los que están desarrollando muy buenas ideas y otros estados que realmente no han hecho suficiente. La misión y los valores que nosotros hemos incorporado en nuestro sistema en el estado de Washington es que las personas que necesitan servicios y apoyo a largo plazo tienen que participar en seleccionar cómo y cuándo se les van a proporcionar este tipo de servicios de cuidado. No es que es algo que te va a dar alguien, sino que realmente se tiene que tener una participación activa en qué es lo que necesitas, qué es lo que esperas. Entonces se tiene que tener una expectativa de la calidad de vida, dignidad personal, que sea algo posible, que se tenga un grado de independencia máximo. El sistema en sí, hablamos de esta calidad de los cuidados y nosotros realmente nos enfocamos en esto, pero tenemos que hablar de la importancia que tienen los consumidores y del impacto que nuestras acciones tienen en su calidad de vida. Realmente a veces tenemos gente que no está muy contenta porque realmente en lugar de estar en lugares donde los cuidan, les gustaría vivir en sus casas y estar en la comunidad de sus hogares. Al principio, y esto no es como en la Biblia, como en el principio de los tiempos, no, solo es un decir. Entonces, en el estado de Washington hemos tenido, no se mostró mucho interés de la parte ejecutiva del gobierno en desarrollar estos programas a largo plazo. Creo que realmente ellos tuvieron más prioridad en educación, pusieron las prioridades en la educación, y esta parte de el cuidado a largo plazo se hizo una de esas cosas con los que no querían lidiar en ese momento, ¿no? Para las personas que están envejeciendo y que tienen algún grado de restricción de movilidad o discapacidad, nosotros tenemos diferentes oficinas y diferentes divisiones en el estado del Departamento de Servicios Sociales y de Salud que les pueden ayudar, pero todo está muy separado. Realmente sí hay comunicación y sí hay comunicación para darle el servicio a estas personas, para proporcionar los servicios, pero son filosofías distintas. En este punto, los valores que nosotros estamos utilizando es ofrecer opciones de calidad para aquellas personas que necesitan estos servicios en el largo plazo. También tenemos una legislación federal y hemos estado pensando en estas cosas y desde 1965 hemos tenido legislación que han sido aprobadas a través de leyes que han creado estas atribuciones a nivel federal en programas como nutrición y algunos programas que les ofrecemos a nuestros ciudadanos más viejos. Pero básicamente se dice en la ley, se dice que recae la responsabilidad en las diferentes agencias del gobierno norteamericano. Y
que esto podría beneficiar a la población adulta. Y después lo importante pues es empezar a meter en la ley los derechos humanos, en particular para los centros de salud. Y bueno, de ahí surge Medicare, que es el seguro de salud para toda la gente con discapacidades, y Medicaid es el instituto para las instituciones para la gente de bajos recursos. Y esto incluye que si ustedes están en el estado van a aceptar este programa porque no necesariamente están obligados a ser parte de Medicare, pero ahora sí se han visto que bueno, tienen una participación y obtienen una participación por parte del gobierno. Y mientras más agremiados haya, más beneficios obtienen por parte del Estado. Y uno de los requerimientos, además de prestar servicios de salud, es brindar servicios de atención, como de asistencia social. Y para la gente con bajos recursos, pues que no tienen esta opción de ir a casas de retiro. Y entonces, ¿cómo queremos que sean esos programas? Bueno, yo sería muy cuidadosa para determinar cuántas titularidades pudiéramos establecer para una locación, porque esta es una lucha que los diferentes ministerios siguen teniendo en las instituciones de cuidados, pero también para los consumidores a partir de los cuidados en casa. Y la población con discapacidades también crearon esto para que le llegara a gente que no estuviera institucionalizada. Y hay, digamos que tenían que eran adecuados para atender a la población, y eso también es parte de la ley. Los estados implementaron esto en cierto grado. Y ha habido casos que ya llegaron a la Suprema Corte en Estados Unidos que enfatizan el hecho de que bueno, que hay que buscar las alternativas más restrictivas para algunas personas. Hay quienes todavía quieren continuar con diferentes estados y involucrar al Departamento de Justicia y hacer investigaciones para ver si la gente está cumpliendo con los ciudadanos con discapacidades. Y en 1986 tuvimos que ver con esta decisión, cómo organizarnos y establecer nuestra postura ante los consumidores que iban a de estar cuidados a largo plazo. Y entonces, en el Departamento de Servicios Sociales en la época hubo una agencia que se llamaba la Administración de Servicios para Adultos y Adultos Mayores, y la otra oficina que era una entidad regulatoria para enfermeras, y la de Servicios Residenciales y Comunidades. Y todos estos los colocaron en un solo lugar para recolectar en un solo cajón el presupuesto, y todo iba a aplicar para cuidados a largo plazo. Y créanme, no ha sido algo fácil, pero se convirtió en algo que era muy obvio, que ya lo habían hecho en Oregon, y tuvieron mucho éxito al mantener este alto nivel del interés con los funcionarios del gobierno y los legisladores. Y no solamente lo hizo la gente del gobierno, tenemos otros grupos y organizaciones que, aparte de Washington, que hacen estos servicios de defensoría para cuidados a largo plazo. Y casi todos estos, al momento en que se creó esta administración de servicios para adultos, pues esto todavía no operaba en el Estado, pero ahora ya tenemos este derecho para entender quién tiene estos derechos y deben de entrar en la CEU. Y no es que vayan mejorando los derechos para los trabajadores y todos esos aspectos para los trabajadores consumidores, sino que también es involucrarse en las discusiones políticas sobre los programas de cuidado y cómo esto puede afectar a los consumidores y a los trabajadores. Entonces, cuando se creó esta administración para adultos y adultos mayores, se sintió que a lo mejor necesitábamos algo más que una buena coordinación, porque teníamos que quitar estos sesgos entre Medicaid y Medicare. Y la parte interesante aquí, a lo mejor para mí más que para ustedes, es que el interés a nivel interno surgió porque había una crisis presupuestal. Y se dieron cuenta que el programa que era como un gasto a discreción, pues teníamos el riesgo.
consumers that we don't have the right services for. There are a lot of issues with workers that needed to be addressed in terms of better wages and benefits and training, recognition of the value of the job and how important it is. And so SEIU became a major factor that Mariana will discuss in more detail in her presentation. And we kept looking for any new financing mechanism we could find that might replace State General Fund or at least help fund a service in the community. And when the federal government instituted new programs like Community First Choice and other kinds of Medicaid waivers, we took advantage of them. And then the legislature actually created, after all this time, a committee, and it's not the same type of committee that has hearings and passes bills, but it's a forum, bipartisan, where they talk about aging and disability issues. And out of that, the legislature got interested in this idea that the private pay individuals are the ones that don't really have a system available to them. And the Long-Term Care Trust Act came about, which basically is a very small payroll tax. And if, I forget, you have to be a certain age, I think, I can't remember. And it's just newly created. The first payroll taxes came out this year. And so in a couple of 3 years, people will be able to access this who are eligible through showing that they have a certain deficit in activities of daily living. For an amount, they'll have there's a certain amount of money that they can spend. And I don't mean they get this money and spend it. It's done through a system to help meet their needs. And it will be the beginning of actually helping private pay individuals. We also had to deal with more behavioral health issues in the system, and that was, more training for home care workers. And of course, the pandemic caused a lot of issues with the needs for protective equipment and looking at the types of way we provide services to help reduce infections. This chart, I'm not going to go in a lot of detail. And when it talks about 40 years of innovation, I don't want you to groan too much. It's more of an issue that you got to start somewhere, and you got to find that niche that somebody's going to grab onto if you have a need for a government leader or some sort of legislative official or some sort of committee, something that they have an interest in. And over time, I've noticed that as legislators themselves age, they finally realize that their mothers and their fathers need care, and oh my goodness, the system doesn't necessarily address this issue, and what about these private pay people? And all of a sudden, you have a little bit more interest, which is something to grab a hold of. And there are many issues, again, that we dealt with here and that I've talked about. Getting more federal financing, for example, was something that you see woven all through here. And we have an automated assessment that provides not just the determination of the functional eligibility for somebody, but aggregates all this data that shows, where we're going with acuity, where we're going with the age of consumers. And one of the factors we had is we have a growing number of people with disabilities, younger people, under 65, who are part of the home and community-based population. And that is, something to watch. I mean, it's a success of healthcare, that there's more diseases that can be treated successfully, more accidents that can be treated successfully. There's also some disadvantage because some of the issues that people end up with, like traumatic brain injury, are difficult for them to live with. And services have to be designed around that. Now, this statement up here looks like we're bragging why our system is better than most other states and what most states don't have. And the only reason I put that there was that a few years ago, the national organization of AARP, and they just use those initials now. And you might be familiar with American Association of Retired Persons, but they don't call themselves that anymore. They're just AARP because you can be eligible when you're 50 years old to be a member. They have a policy institute. And the woman there had been involved in providing long-term care in a different state. And she's a researcher, and she's very, very interested in long-term care. And she got money from AARP, from 2 other foundations, the SCAN Foundation, the Commonwealth Foundation, to start an effort that ranks states in terms of their success in long-term care. And the idea was, as some of the people from Brazil are afraid of you want something to be developed in your plan that will stay and maybe not be affected by any next government change. There's a lot of change in long-term care in state governments in terms of who the leaders are. And this scorecard is what they called it. And if you Googled it, it's kind of like AARP, long-term care scorecard, ranks all the states in certain characteristics. They had to make sure that they had data available that was good data and that was planned to be replicated on a periodic basis so they could see not just this piece of time, but 2 years from now, 2 years from now, and 2 years from now. And I think they've done this at least 5 times now. And Washington State has been number 1 or number 2 every single time. And other states that are real up there are Minnesota and Oregon, for example. And what she hoped to do, but she doesn't personally feel it's been successful yet, because it's kind of in the intro of this year's long-term care scorecard, is to be able to take a leadership change and have them understand where their state is and have them start the discussion about what kind of improvements they want to make. And it's interesting that there are a variety of states that sit at the bottom and continue to sit at the bottom. And so there's a lot of work to do. And I've often said at some conferences, if you don't do something, you're welcoming the Department of Justice in your front door, because they will see that you are violating the Americans with Disabilities Act. And there's a state, I've been involved in some of those investigations, and you know, they're still doing work on that. They used to, Department of Justice used to concentrate their resources on doing investigations of civil rights of persons in institutional care. And they've switched those resources to look at what states are doing on the home and community-based front. So just in relation to this, I mean, we continue to have consumer choice drive the long-term care system. And that's the thing about where do you want to receive your care. And originally when we started this and had to do the budget part, we thought people who lived in nursing homes would probably have to be served like in an adult family home or some type of community residential care. And if you look at the statistics of what happened with a number of people, we somehow ended up having those people living at home. They might have still had their home, or they might have gone to live with a relative, or there might have been a subsidized apartment available, and they went home. And we were wrong. And home care became a bigger and bigger issue. And especially with the younger people with disabilities, it still is what they want to receive. So it just kind of says that the consumer's in charge, one service, not one service is more important than another. And we've been able to do this again because of the single organizational unit all working together on the same mission and going in the same direction. We do in the system have a standardized way to assess financial and functional eligibility. We have a case management system which the people who work in that, whether they're in state government or in local area agency on aging, they are independent from long-term care providers. So you don't have a provider deciding whether you're eligible or not. And it's conflict-free case management. We leverage the assessment in terms of integrated data system to derive decision-making. We have quality oversight in all of the parts of the system, from home care through institutional care. And we continue to appreciate the fact that there are articulate, sophisticated consumers, families, and providers who advocate for this system. And these are just a couple of slides that demonstrate some of the things that I've talked about. This chart starts back in 1992 and shows basically the division of how many clients are in home community settings versus nursing homes. When we started the long-term care reform and we had the authority to go into nursing homes and also divert people from nursing homes, there were 17,000 Medicaid clients in nursing homes. Today, there's less than 9,000. And it's just interesting that you have a growing population of older people, you have a growing population of younger people with disabilities, but you don't have to run to the service nursing homes right away. It's just not what's happening. And we honestly thought this drop would discontinue after about 12,000. It keeps on going on. And the end of this, basically we have 8,300 people in nursing homes. And then the community is made up of people who are being served in adult family homes, assisted living, and but the in-home population in this chart is about 48,000. And that's just in the aging and long-term support administration, which is what it's called now. There are also people with developmental disabilities who are getting home care, and they are not in this chart because they are in a separate division. And then you may not have to do this, but in order to start our program and continue our program, we had to show that we were generating savings. And some researchers in the Office of Research and Data Analysis took this job on to determine if we'd saved money or not. And basically, the cumulative savings that they came up from basically reducing institutional care, serving people in more cost-effective settings, shows that over this period of time on this chart, we saved $4.9 billion. And I want to switch to Mariana now to talk specifically about the role of SEIU and how helpful that's been in terms of worker enhancements as well as being involved in the policy.
Thank you, Kathy.
I need to turn something off here.
Hola, buenas tardes a todos. Mi nombre es Mariana Morante y trabajo en el área de investigación, política pública e innovación con SEIU 7.
So as Kathy was saying, I will talk a bit about how this union was organized with home caregivers, and this has been like for 20 years. And somehow, how you have been discussing this in the first panel, we have this cultural, social, political, historical context that has passed through diverse states, diverse countries, and the US as well. And this has established the labor conditions of these working people, how they are classified, and what rights and benefits and salaries they should deserve. And the first topic is gender, because we say that this is a labor that should be paid, but then there is another one that is private, not non-paid, and it has no economic value. Hence, most of the times this labor is carried out by women. It's unpaid, and it is non-intrinsically acknowledged. And well, this is a context that includes racism, and in the U.S., the white race prevail, the white supremacy. Historically speaking, this work usually was achieved by black women. when slavery was abolished, and then the country is conformed or integrated, these tasks carried out by black women continue to be not praised or valued or included. And Kathy was talking about these systems that we're talking about social security. Like all these labors, these type of labors were put aside. This is why these women were out of the National Labor Relations Board and other systems. These are the regulations that create the labor and paid standards, the right to be part of a union or not. And under this context, these female workers remained, and as I was saying, black, migrant, and racial profiled entities, and they are at risk of exploitation without having access to allowances or benefits. And additionally, they end up working under this context, and they require labor flexibility or work only in part-time fashions. Single women, single mothers, isolated parties working at other houses, like caregivers for other parties. People that have been racially discriminated, and the huge majority, above 80%, this trend falls in working women. And at the same time, this falls in earning very low salary and lack of benefits because they are not protected by the labor regulations in the U.S. Same as here in Mexico, the situation of trabajadoras del hogar. Housekeepers. Same as in the U.S. Let's say you are hired by a family, a private house. You lack of legal protections. You are subject to violence, exploitation, and there are no protection mechanisms. And let's say what I do at the office, I am in contact with other people, I have my peers, workmates, housekeepers, houseworkers. They lack of making connection with other peers, other people, and this makes the organization of these people hard because they cannot work or establish a union because they are working at private spots, and they cannot gather in a union. For example, in the state of Washington, working people or home workers, they provide Medicaid services, and even though they were paid by the state, they were not considered as state workers, so they didn't have the right to be part of a union, and this was one of the obstacles that they faced in the beginning in the state of Washington. But what happened to these male and female workers to tackle this obstacle? First of all, understand that syndicalization of workers was like the straightforward and more sustainable pathway to get to these salary improvements and benefits and improvement of their labor conditions. So in 2001, during the session at the Congress in the state of Washington, they started working with other legislators to approve the law that basically would say that these house workers providing services through the Medicaid program paid by the state would have the right to integrate a union, but this didn't happen. There was no voting, nothing happened. Since then, these workers, together with CIU, started to organize what in Mexico would be something similar to the public consultation or citizens' initiatives. These are the ballots initiatives where voting parties in the state will determine about this issue specifically and determine if these house workers or home caregivers will have the right to organize a union. And this is what we did.
It is really complicated as in Mexico. You need to put together signatures and a lot of barriers you must overcome to be able to reach that moment. And after getting organized, for example, with the council of elders, with the families and the customers, they achieve to do so. In 2002, this ballot initiative was passed with an approval of 63% of the voters of the state of Washington. From there, people, the workers, domestic workers, had the right to create a union. So the next step was the voting. Voting to decide whether they wanted to go for a union or to be part of EIU 775. Number 775, that was the name of the ballot initiative it was Initiative 775. That's the reason that SAU took that number into his name. And so Andrew told me, our vice president, he's here, he told me that this part of the process was the simplest, just to count the votes to go for a yay. And then after that, we achieved our first collective bargaining with the state of Washington. That was really complicated to achieve. I was not working there yet, but it was a process where we were kind of on a horse race, because we had to deal with a lot of obstacles and a lot of things that were coming into. So in 2007, through these processes, working with the legislators, with the collective bargaining, and with our allies, we created the training partnership, which basically is an alliance that between the state, the employers, the unions, to provide and to provide training for the people who work in domestic care in the state of Washington. Today, currently, more than 20 years after, SIU, it has more than 50,000 members in Washington, Montana, and Alaska states. We represent mostly people who bring care at home, and also some people who work at nursing homes and care homes and other places where elders are being taken care of, or people with disabilities are taken care of. Women are most of our members. Women with racial profiles identify as Latino, Black people, and older than 55 years old. And of course, this is starting to change. There is a trend that we are getting younger people. And also, the other consideration is that since a long time ago, the care, this is one of the most, it has a really fast rate of growing. The amount of, demographic changes that we're having, but also what people are going through. People are living more. Disabled people are living more. It doesn't mean that we are living in better conditions. These represent a challenge, and that's the reality of why training is so important, because the care that people need are becoming more complex and specific than they used to be. This is something that I like to present a lot. This is a difference that has been made. This is the difference that SAU 775 has made. Maybe the numbers are really tiny, but the purple color, it is a wage. It's the average wage of our care worker at a national level. And it is about $15. This is data from 2022. And so if we compare it with Washington State, we have our workers, the more experience they have, the more years they have been in the system, they have more steps and their wages are higher. And compare with the average national wage, which is $15, the initial wage of a worker in the state of Washington, it's almost $20, $19.51. And for the people with the most experience, such as Dora, that you saw Dora in the video, maybe she has a lot of working hours, the wage is almost hitting $22 an hour. Another difference is that a benefit of their holidays is not a big benefit. Can you go? Okay. So what we call PTO, they have this coverage, and from this year on, they will have for their kids under 18 years old, they have benefits for their retirement, and in 2025 with the new collective bargaining that we have, they will have an initial wage. The newcomers will have a wage of $21.44, and the most experienced people, they're going to be over $25. Of course, quality training through this alliance with our training partnership. And through years, SAU has worked in pro of increasing the wages, in pro of the workers, a lot of times collaborating with Washington State. Sometimes they do not collaborate that much, but when we are in a negotiation table of a collective bargaining, the relationship can become a little bit stressful, because you are trying to bargain and at the same time you're trying to allocate the money, checking on the cost of that collective bargaining. So 2 years ago, 2 or 3 years ago, we started a movement. We made a transition to what we call a consumer-directed employer. It means that Washington State decided to close the contract with an agency of the with the care workers. They moved them into this scheme, which basically is following the same model between the customer and the company, but it took away a lot of friction between the Washington State and the union. They made all the management matters simpler, which brought more capacity to deal with topics related only to management, and there is a full point of responsibility talking about jobs itself. So what we did with Washington is we created a rate setting board, which is basically a working table where we have the union representatives, workers from the union, representatives from Washington State, employers, representatives from other organizations, representatives from organizations representing disabled people, and all together we decide every 2 years what are the reimbursement rate. So how much are we going to pay hourly for these care services at home? And this is an open discussion, in which is something really important for us, is that the workers have a voice on the table. These are my needs, these are my experiences, this is what I've been through, this is the reason I'm asking for more money. We're talking about the demographic changes in an open conversation, in a collaborative discussion, which used to be in a bargaining. And once that the hourly rate is set for the company, then the union set up a collective bargaining with that company to decide, well, this is the hourly rate, and you can give this percentage of wage increase, and you can cover these benefits. And so we start negotiating our collective bargaining. So that money, how are we going to use that money? That's the situation in which we are now. We are going to have this working table next year in April. We're going to this rate setting board in April 2024. So, drawing out a conclusion for the conversations that we're having up to this point, it is important to mention that the acknowledgement through the right salary to the people who take care of people at home, it's important. It is important to take into account the mechanism that we use. And I think that it is not only to allow for them to have benefits, but to make sure that they become professionals. And at the same time, this provides feedback at the time that they ask for a wage increase. This is a really important job that they are doing. Thank you very much. No se escucha el micrófono. Thank you very much, Katy and Mariana. I think that the model that you build up with all your effort, with the effort of the government officers, the union, it has created a model scheme, a model system. All the people who is taken care of, they can decide. The caregivers can decide. They can have benefits such as retirement fund, organization, training, and the ability to negotiate under working conditions. Congratulations. So let's wait let's listen to the next two panelists. Of course, I imagine that there should be a lot of questions for our colleagues over here. Now we are going to go for I'm going to switch into English again. Ahora vamos a escuchar Kellyanne Orr. Ella es la asistente de Unifor Canadá y es responsable por el sector de la salud. Y estamos muy emocionados de escuchar de sus experiencias en Canadá. Muy bien, muchas gracias. Estoy muy contenta de estar aquí con ustedes el día de hoy. Gracias por la oportunidad de darles la perspectiva de Canadá y el contexto de la Organización de los Trabajadores de la Salud en Canadá. En Unifor tenemos más de 30,000 miembros. Somos el sindicato del sector privado más grande en Canadá y uno de estos sectores de los cuales formamos parte es el sector de la salud. Tenemos muchísimos miembros en este sector. Ciertamente nos encontramos ubicados geográficamente en Ontario y en Nueva Escocia. Ahí están nuestras oficinas y tenemos todo tipo de servicios, hospitales, cuidados a largo plazo, casas de asistencia a la tercera edad, clínicas. Cuando hablamos sobre cuidados en Canadá, nosotros hablamos de un trabajo que incluye el contexto del sistema de salud. Y nosotros, este sistema de salud lo llamamos Medicare. Medicare es un sistema universal en el cual la persona generalmente no tiene que pagar por aquellos servicios que cubre Medicare. Medicare se enfoca principalmente en cuidados hospitalarios, cirugías, atención de primer nivel, y esto va con fondos del gobierno federal que van directamente hacia Medicare. Pero Medicare no cubre todo. Hay muchos servicios de salud como oftálmicos, seguros dentales, medicamentos de prescripción, cuidados a largo plazo y cuidados en casa. Estos no los incluye. Medicare, Canadá es uno de los únicos países alrededor del mundo. No tenemos un sistema de salud universal, pero no tenemos un sistema de cuidado social que sea realmente integral, o un sistema farmacéutico nacional. Entonces, esto no lo incluye el programa del gobierno federal. Debido a que Medicare no cubre todos estos rubros, tenemos una situación bastante fragmentada en nuestro sistema de salud y es bastante ineficiente. Esto se divide en cada provincia. Cada provincia tiene que ver cómo soluciona estos problemas, ¿no? Sí hay algo que tiene un alcance federal, pero cada una de las provincias puede decidir cómo utilizar su presupuesto y en dónde va a poner ese presupuesto, dependiendo de las prioridades que tenga cada uno de las provincias, territorios, será como utilicen estos recursos. Debido a que Medicare no cubre muchos servicios, estos servicios se tienen que dar por operadores de la iniciativa privada. Esto significa que muchos servicios se brindan parcialmente o totalmente a través de las personas que tienen que pagar directamente de sus carteras. Entonces, esto ha representado una privatización de este sector de la salud, especialmente en donde los trabajadores no tienen ningún tipo de prestación social, no tienen un sindicato, no tienen condiciones para hacer sus contratos colectivos o para tener seguro dental o de visión. Debido a que Ontario es la jurisdicción más grande y es en donde tenemos más miembros de Unifor, vamos a utilizarlo como un ejemplo y en el contexto de los cuidados. Entonces, para pacientes, tenemos un criterio de elegibilidad para los pacientes dentro de nuestra provincia. Entonces tenemos un sistema con el cual vemos a quienes les podemos ofrecer este servicio, quienes son elegibles. Y generalmente esto.
Many people who should get care, but it's so limited. And those that are partially covered end up having to pay out of pocket. And of course, you know, if they don't get the care if they can't afford it. And it's usually always provided, home care is provided by the private for-profit companies. And then, of course, for the publicly covered home care, the government contracts out those services to the private companies. So they give the private companies money to say, okay, you here's some money for the public portion that we're going to pay for. The for-profit motive for home care and healthcare services in general presents, of course, a number of problems. Public tax dollars are subsidized to private companies for essential services, and companies typically operate in a way that they want to maximize their profit. So that leaves less money for direct care. There's usually lower staffing levels, there's less compensation for the staff, and of course less supplies. So, and then of course there's data from the Ontario Health Coalition, and in 2015 we had an Auditor General report that suggests that half of the funds that the private operators receive go to administration and profit. So that's half of what they receive. And the delivery of home care is largely already controlled by the for-profit companies, and then the province, of course, contracts out the funding, their funding to them, and this allows the restructuring and expanding of privatization of the sector, which only serves companies who they'll siphon off public funds from our healthcare system. It allows for private companies, of course, to coordinate the home care. It's a new bill that they're going to pass. It was streamlined. It's called Bill 135 in Ontario. And our government, our provincial government has decided that they don't want anything to do with home care. They'll just throw some money at the private for-profit companies to deal with it. But they also, we're going to lose our public what do you call it, control. So our public control is not going to be in home care, it'll be up to the private clinics. So that's very, very concerning for us right now. So our privatized home care structure has significant impacts on workers, of course. When you look at the privatized system in home care, the wages and compensation are driven down. We have a lot of high turnover in staff. There's a lot of workload overload, and they're overstressed, and they're just leaving. They get some experience in the home care sector, and then they go on to a more stable employer, right? So they just, and then what happens is there's staffing shortages in the system, especially in home care. And of course, again, just like workers, when it's a privatized structure like that, then it impacts on care. And with the staffing shortages, of course, there's no continuity of care. There's less time for home visits. There are people that, you know, they're supposed to get care and nobody shows up because there's just nobody to take care of the patients. So most of home care workers, so the challenges in unionizing the members is that most of the home care workers go from their own home to their clients' homes. They don't have a central workplace, and now employers, they connect with their employees through email. They give them their schedule through email. They don't even actually see their own employees. A lot of the employees will have even their gloves and their masks shipped to their homes. So that it's not there is no, you know, core place where they're meeting and greeting each other. So they never even meet each other. So when we try to organize home care, it's a real challenge because even though, you know, we may have been approached by people to say we want to unionize, they don't know who each other are. They don't know how big they are. We do have an active campaign on right now in southwestern Ontario. It's a large area, but geographical area that we're trying to unionize with home care workers. The positive thing is they are expected to go to one work site, you know, to get their gloves or to meet and greet their employer, but they don't do it regularly. So it's just hit and miss, and you know, it's a matter of us getting out there and getting them to sign cards. And then the problem is with the staff turnover, by the time we get cards signed, they're already gone. And we have to have 40% of the membership sign cards in order to you know, have them unionized. So even though that they're desperate for a union because, you know, their working conditions are terrible, they're not getting their, you know, their breaks because they're in somebody's home and they're not allowed to. They have a lot of injuries because, of course, somebody's home is not set up, you know, ergonomically for them. There is some, you know, we've heard of a lot of misconduct because there's somebody else in the home. that may be harassing them in some way. So there's a lot of issues. The employer's not providing them with proper PPE, proper gloves in order to take care of the patients. They're putting in those, I don't know if you have them here, but the lifts that go on the ceiling lifts. But the ceiling isn't equipped to hold the lift, and so they come crashing down on them. So there's a lot of workplace injuries with home care workers, a lot of frustration, and it certainly is difficult to get them to unionize. The other thing I wanted to talk about was in Ontario as well. The Ford government, we call him the Ford government. He should be somebody that shouldn't have a name, but he's our premier in Ontario. And he passed a bill in 2019, and the bill in 2019 was that all public sector employees were limited to a 1% wage increase, total compensation for 3 years. So we lost our right to freely bargain for public sector workers, which were healthcare workers, social workers, so those in hospitals, social services, and he exempted, and of course you all know that there are female-dominated jobs, and he exempted fire services and police services, so they could freely bargain with the to get increase in wages. And he did this at a time when we were in a pandemic where we were supposed to be heroes, and yet he's telling public service workers that work in healthcare and education that they're only worth 1% total compensation. So that's not just wages, that's benefits, any kind of benefit improvement. So it was very, very frustrating. So every union got together and we challenged it with and we took them to court. It took us 2 years, but we won. And we ended up getting the right to go back and freely bargain the wages that he had imposed on us, the restrictions. But now, of course, he's appealing that as well. But that just goes to show, you have to be careful because governments, depending on the government of the month, what they do with our healthcare, how powerful that they are, and so we have to really be concerned on who we elect into those government positions, because it could change drastically our social services and healthcare programs. So that's it. Thank you.
Muchas gracias, Kellyanne. Y es muy interesante el dato que mencionaste de que de los fondos públicos, interesante el dato que mencionaste que de los fondos públicos que pasan a través de las agencias privadas, que la mitad no llega a los cuidadores, o sea, es para la administración y el lucro. Y sería interesante comparar, por ejemplo, con un sistema como tienen en el estado de Washington, qué por ciento de los fondos públicos llegan a los cuidadores y realmente al servicio de cuidado y no a otras cosas. Bueno, ahora vamos a escuchar de Ruth Díaz, presidenta de la Federación Nacional de Mujeres Trabajadoras de República Dominicana.
Bueno, muchísimas gracias, Alan. Saludar a todas nuestras panelistas, las que me acompañan en la mesa de honor, y sobre todo a todo el auditorio.
And the whole public, whole audience. Our host here in Mexico, thank you for this opportunity, and UNI, who is still developing challenges and advertising about what the world requires. And I would like to underline the participation of my peers, Mercedes Ferreira, the dirigent leader of the federation in our country, and Francisco Garcia, who is in charge of the largest nursing group in the country. And with the honor that part of the Dominican Republic is represented by Diana Mejie, representative of CONAPE, and I cannot put aside Adriana Paz, the current secretary of FIT, who is also part of the International Agency of House Workers. As you can notice, UNI has allowed us to come with this broad spectrum. I'm talking about caregiving in the Dominican Republic. Dominican Republic is, I am part of this home worker association, and we have been for several decades working on these caregiving factors, but it wasn't until post-pandemic that this was set as a manifesto. The requirements we have been demanding, house workers, we are talking about health care system, the assistants, the staff that is perhaps is not wearing white robes, but they are essential for the whole system to operate. This is child care, institutionalized and home child care. But we are talking about seniors and aged people. Yeah, we do have this young population, but demography around the globe has demonstrated that more caregiving and more caregivers are required. According to UNI, the statistics show that the figures in the future year compels us to be present at this type of fora and make decisions on the name of the government. I'm talking about formalization. We do understand that caregiving implies different links, and they are all somehow gathered regarding public policies, infrastructures. We have to look at these policies as the core topics to include housework as something essential. No one can provide a quality service if the house is not duly clean, covering all the standards, so you can go out and produce at an office and at a work out of home. So housekeeping is like one of the main pillars, because from this, the other actions of any productive life detach. So we do understand that any labor to be formal should include several components. We are here today working about three main components: training, organization, and skills development. But we need a salary. It is not the minimum wage that wouldn't allow us to have a productive life, and that where people cannot enjoy and cover their needs. It should be a productive salary. It should include the correct organization and should be guaranteed by an association and social dialogue. We bet for social dialogue. We understand that the essence of the ILO should prevail in all areas, and one of the guarantees provided by the Dominican government is that the possibilities that we all unions can be present and can have incidence in the decision making with different actors. That's the Ministry of Labor, the Ministry of Health, the healthcare table, they allow us to be present and be part of the decision making. Another example, some days ago, Alan and Lucia were in the Dominican Republic, and we were invited to the healthcare table. And the three institutions therein gathered were present, and we were capable of filing part of our vision. When we see this type of articulation, that it sometimes 10, 12, even 17 institutions should be gathered to understand what a woman is capable of doing, because we all agree that women are the parties who have guaranteed throughout the years the health caring issue. And since we are life givers, we take care of our children, teenagers, etc., until we become caregivers of seniors. So with this we have the clear vision that the following 20 million workers as caregivers, what conditions, what labor conditions they will be having. So we have to see this as the state. The government should understand what type of citizens they want to have in their countries. Who's getting these benefits? This is why we demand it to be from the public funds with creative models that adapt to each and every country through the social security systems. Today we cannot think that someone providing this transcendental profession for the GDP and the profit of countries should be paying taxes. No, these taxes should be covered by the companies, because thanks to these corporations, to these professions, corporations are being more productive. But this should be attached to the social security systems as any other service delivered. Could I go to understand if I'm pregnant, if I'm going to a social service because I got the flu, my retirement pension? No, if I have this requirement at home, then some of my dependents should be cared of, or myself. This is like the main challenge that we understand we have on the table. But we have like several examples of the different visions present. Today we were talking about the fact that it is not that an action or a policy is not the same as a system. Unions as social actors aimed for transformation and for the change, we have to guarantee that they become systems, notwithstanding the type of government. For example, in Brazil, that they went back so much, even though they had everything arranged, they cannot allow this to go back again, because improving services and the quality of services of workers devoted to caregiving is refusing quality of life and sustainability of any country. This is why we understand and we are deeply convinced that the pillars that integrate decent labor should be interweaved: salary, social protection, going beyond social security, and the insurance coverage like healthcare, pensions, labor risks. All these services should be delivered in an environment that guarantee physical integrity and the ergonomic capacity of the caregiver. No one cannot give what they don't have. If these parties are not duly covered, then how they will be covering and protecting the parties they are giving care to? But when we talk about protection, we also include the array of projects that come up from all this. We are working on the ratification and implementation of crossover projects. One of them is Act 189 that has to deal with housework. Latin America is the leader, pioneer in ratifying this, but we are so far away from implementing them. And we're also facing the challenges of 183. We heard Paz from ILO. She was talking about maternity and the guarantees for men to get involved in caregiving to their children, family responsibility, labor life. The burden cannot only be carried by one of the parties that is working on paid conditions. And Agreement 150 that talks about all types of violence present in the labor world, notwithstanding where they are providing the service, at institutional levels or at home caring levels. So it's social provision, salaries, be heard, be capable of collectively agreeing in projects. It's not the same to have employees spread away with different requirements. No, having key acting parties so that they can exchange the processes that will lead to these eventual outcomes. And we to have the capacity of proposals, smart people with capacity of improving, and to do something, not because the governments don't know. UNI gathers unions on a daily basis, and who's better to talk about our requirements, workers, and finally training, which is significant as well. And I will run a video with Sinamutra giving examples of training and education. If we're demanding rights, we have to comply with our duties. And I am a worker, and they should be duly certified with caregiving to include all categories, to include housework. This should be duly certified because we demand workers that are beneficiaries of all common rights. From our organization, it's clear for us. All the pillars, all the situations weaved that will lead us to sound and actual facts, not only for caregivers, but for the quality of life of citizens that will reflect their well-being at all levels. In a world in continuous evolution, Senamutra rises as a lighthouse for the change. Senamudra was created to the scarce visualization of women, but they had gone beyond. It is the union that brings support to the working women in different spots to be recipients of their rights, and it not only covers working women but empowers them for different services that are open and available for them all. We have our own cooperative in which we can give loans, financial and planning counseling, and financial education for SMEs and house workers. All these services can be managed through our WhatsApp number, and we also provide school credits, life insurance, loans for vacations, and we provide all these benefits for women. Senamutra also trains in sanitary affairs, house workers, and caregivers for infants and seniors. Nobody is left behind, and we do not minimize anybody's work. We have gotten agreements, collaboration agreements with the different associations in the Republic, in the Dominican Republic, to improve the quality of life of seniors. We are backed up by Infotep as the operational centers, IT centers, so that they can learn at excellency levels. We have this training center for house working duties. We are committed to train with quality for free, complying with the best, with the top standards. We also develop the capabilities of caregiving, from houseworking, risk management, attention to elders, and caregiving to infants, and also jewelry making, industrial kitchen, bakery, cooking, and we have our own textile center. So here we are the force for the change, improving the rights of women, offering services and benefits and information that will transform lives. Watch out! FENAMUTRA has its own cooperative so that they can provide economic assistance and finance education to our members. But we do not agree in the cooperative of our members. A member should be duly represented and in the social dialogue with the employees, with the workers, and fully led by governments, because they will be guaranteeing the welfare of their citizens. Thank you very much.
Muchas gracias, Ruth. Ahora tenemos
Well, thank you, Ruth.
preguntas.
So now let's open the Q&A session. Adriana.
Bueno, muchísimas gracias a todas. La verdad que
Hello.
muy interesante. Pregunta en particular para Mariana.
I have a question for Mariana.
¿Cómo, en realidad son dos preguntas.
Well, two questions.
¿Ustedes se vinculan con los trabajadores o
How do you
empiezan a trabajar para que
link with workers so that they become members of the union? How this evolves? And then the question, this might be, how did you get the union quotas? How they are paid, one-on-one, or it is directly reduced from the payroll and then credit to the union? How this happens? Well, the way we do it today, it's through different channels. One is the consumer of director employer, the company that manages the administrative affairs of workers, and they are compelled to give us notice. And this appears in the new collective labor agreement. If it's going to be counseling, how this process will be managed, and then we go down to the spot and give some training. Our trainers go to these spots, and they talk about the union and what is involved. Quotas. This is also stated in the contract labor, and this is run by the employer, and they can opt out. They can determine if they want to opt out, but this is through the employer and another automatic basis, and they have to sign their employee cards. How can we notice, how can we realize to reach the newly hired employees. Because for this purpose, I think we should have direct dialogue with that person and provide them with the correct information so that they can defend their rights. Well, this is a very good question because for us, what is essential, and most of the time it's like the first step. Most of them are relatives or friends and have been developing this labor for many, many years. So it's like talking to them so that they can understand that they are running a labor that should be praised as labor. So making this personal connection to understand their backgrounds, because at the end, house workers, we understand it's labor, but at the same time, they do this from their hearts, and it implies emotional feelings. So it's talking about their personal stories, and that they perhaps have been workers sharing same obstacle experiences, problems, experiences, someone said even loneliness. So when they are together, these workers start connecting. They connect with each other. So they have like this power when they are all together, and then they understand they are not only them. Out there, there might be like 40,000 workers doing the same, and when they gather together, it's so powerful. So for us, it's essential when we put them all together, gather them all so that they can personally meet each other, understand their backgrounds, and they understand the power they have. When the Congress is at the pro-home presence sessions, and we are at the legislators' offices. We go almost every day, and then there are always groups of people with their claims and demands, and this is what I do, and this is what I need. Like them all acknowledge that they are a political force, social force, and a transformational force. And this is quite useful. We run this annual conference, they gather all together, they exchange information, but yes, this is through their personal stories. When they realize that perhaps what they do is a solitary labor in just one house, but at the end they are not on their own, and that they share the same with thousands of other workers. I think this is where the best power is when it appears. And for us, union leaders, we can understand the relevance of unions have through UNI. UNI is a union. Beforehand, no one has ever considered the relevance of caregiving. So caregiving in general has a name because it's not only education and health. These are general topics, and let's understand how UNI considers this field. How many people need, not only at hospital with us nurses, no, everybody out there, they even need more than those who are at a hospital, because at a hospital they have positive care provision, but out there they don't know. So who was the first, who established this union? UNI. We should be so proud of being part of this union because, again, we are talking about different types of care. Even painters, personal care for people with psychological issues need to be cared. Yeah, when we talk about care, the topic is so broad. Thank you, Mercedes. So it's Ulises, Diana, David, and then coffee break. This is for Mariana. I think that in the state of California, they receive this economic aid when they have disabled, when families have disabled children, and the head of the family or the mother, they can appoint a family or a relative or a friend to receive this economic support. Even though they are not duly trained, doesn't this overlap with the scheme you have in Washington, or can these two schemes coexist? Because this is a payment granted by the state, but it is not mandatorily binding or enforced by the state. So what is happening here? Good question. As Kathy mentioned, since we have no national caregiving system, caregiving is one fashion in Washington and another completely different in California, and there are many, many types of programs. We essentially work with workers providing care service to Medicaid people. Sorry, I don't know the name of the program in California. But for example, in Washington, we work with AARP, as Kathy mentioned, groups that work with disabled parties. And in the U.S. and in the state of Washington, one of these things is that only a certain group of people with a certain economic situation will have access to these resources, low-income parties. And these services are so expensive that only the privileged ones will pay it. But in the middle, in between, people will spend all their money until they become eligible for Medicaid, or you fall in non-unpaid services by relatives and friends, and again, the burden falls in the women. How we have coped with all this, like with, as Kathy mentioned, the long-term trust fund, like all working people in the state of Washington will have access to long-term caregiving services. And it is not that you will have $36,000, this is your fund. What the union, and actually many of the involved parties, what we want to guarantee here is that we're not giving them the cash away, so they will spend the money without any commitment or regulations or in compliance with the workers' salaries. No, the implementation of this program, when people have access to this benefit, will fall under certain parameters. Like, you will not give the cash, you will pay for the service, and all workers getting this service should be duly certified or trained. This training, the training for for the friends and families taking care of a disabled party. For example, in Medicaid, you have your family, the family that has been taking care of their son for 18 years, and they know how to take care of their son. But when there is a requirement that they will jump into this program and be submitted to a training, they say, I know how to move my son, you will not teach me at all. It is kind of delicate. But at the same time, we have worked with them for so long, and we say, yeah, there are many things that you can learn and that are necessary for the better caregiving for your son. But the union has struggled to provide the members with this training. Again, it's a profession, it's a job, a dignifying job. So if you give them the cash, it will get lost, and you will not guarantee neither the working conditions, so it will affect the labor conditions, of course, and then the mission of the union, but it will likewise affect the quality of the care that these parties will be receiving. So what we are all looking forward is to providing quality services, guaranteeing the quality of the care provided and the labor conditions of the working parties. Well, thank you all. Thank you for these presentations. Thank you for sharing so great information. Of course, you have lots of years of experience. Mariana, I want to ask you.
The question is, we know that it might be a little bit complicated. We understand the Latin American situation, the Spanish-speaking countries. So when the employee is closer to the employer, it's harder to become organized. You know, if we know that the person that you are working with in the home is not your direct boss, right? But it's kind of complicated, you know. So it's what you mentioned. I mean, what the panelists from Canada mentioned, that the people are all split around. They don't know each other. So I don't know if it is. I don't know, how can we work out things, in your opinion, to avoid this situation of turnover? No, I mean, our colleague over here, she talked about this process of the outsourced workers, that I think that it is really complicated because, you know, the boss is just next to you, and sometimes the customer itself can be viewed as the boss. So how can you boost the trust in the people that we need to get organized, that it is a way to improve their working conditions and to acknowledge their rights? And for our colleague from Canada, towards this situation, as you mentioned, these are just pebbles all around. They don't know who hired them, and sadly, there is a reduction of both the working conditions as well as the service quality, and it does not only affect the workers who are fulfilling that function, but also the people who are getting that service, the people who need that support. So it is a two-way street in such sense. I don't know. I mean, I don't know if there is a legal topic, that there can be any legal restrictions that people cannot come together. I mean, When people leave, they don't work. I mean, how? I think that it is like parallel points, you know, like trying to organize ourselves in such area. So, what do you think that it is a difficulty level to get organized from what you mentioned, that they just leave, that they don't have just good working conditions? They notice that they are putting at risk their own health because they don't have any benefits, as you mentioned, compared to the union that Mariana represents. So, I mean, why am I into this topic? I work in the pre-hospital services. I am a nurse, but we work with urgencies. But talking with the company, I think that they are in which state are you? In California. Okay, they are in California, and I listen to it, that they are going to get people who work as caregivers, care workers. It's not a company that provides professional services, but now they are going to hire care workers. Thank you for listening to me. Mariana and then Kelly. Okay. Mariana. I'm going to divide this answer into chunks. First, in Washington, the situation, the fact that they are so close to their customers, it's something positive. As you mentioned, they are so close that they can get to meet personally. Sometimes they are family members, and the family members also want to get better services. The customer wants better services, and they want that the person who is taking care of them have a good wage. So it is in pro of both parties. And so when it is through agencies, I think that the experience that we have, for example, in the state of Alaska and in Montana, where it works, the state pays, but the state pays towards the agencies instead of having just one agency that has all the workers. We have several agencies, and it is more complicated because of Alaskan geography. A lot of communities do not have any kind of certificate, and the communities are really isolated. So here we have two things. First, when there's a political work, the legislative work, what you can do hand to hand, literally knocking doors, knocking on politicians' doors, knocking on other kind of organizations' doors, and any kind of organization that share the mission that you have to find the care workers and start talking to them. It is a really hard work. It is. I'm not going to lie. It is complicated to get them organized. For example, in Alaska, we're not only in the Congress in the Washington state. All the years we have a representation in Alaska, and all the work of our representatives, it's a legislative and political work. So that's the first part. And the second, maybe because I'm in the research area, I will answer this to you. But the second part is research on the industry. Research, do a market research. What are the agencies that are the bigger? In which geography do they have presence? Where have we been able to contact workers? Here in this topic, in the care agencies, there might be an agency that is in Alaska and it is not organized, but it is a company that is being organized in Montana. So you need to create a map. Who are the actors? What are the market conditions? Where are the care workers? And to start linking the dots to say, well, this is a perspective that we may use to get organized. But I don't really think that there is established formula for that. It depends very much on that first, on these conditions, on understanding the scope, to whom will you be talking to, In the States and in LATAM, I think that it has been really important to use the right words. Language justice. We always say they are workers who do not speak English. So we have staff members who speak Spanish or Vietnamese, Korean. I mean, to understand also what is the ethnic composition of your workforce, to work it out together and to look from different perspectives, to gather all these inputs and to grow stronger. I mean, in Alaska, we tried to get organized in 2017. We did a good job, but it was not strong enough, and we tried again 2021. The first collective bargaining that we have in an agency in Alaska, it's I mean, when we won the vote from the union, it happened back this summer. So it is a work that may take a lot of time. Sí, ciertamente ese es el problema. No. Sí. Ahí está la situación, que te toma mucho tiempo y ahí es en donde pierdes el interés de los miembros. Ahí es en donde puedes perder el interés de los miembros. Entonces, lo que nosotros hemos logrado hacer en Nueva Escocia específicamente es que hemos negociado que no importa, o sea, los trabajadores de cuidado son trabajadores de apoyo, entonces ellos tienen que tener cierto nivel de capacitación, de entrenamiento y de conocimientos. Entonces, sin importar si trabajas en un hospital o dentro de una casa o en un asilo, siempre vas a tener el mismo nivel de ingresos. Hay paridad entre las diferentes juntas, hay registros específicos. Cualquier persona que esté trabajando en un hospital tiene que tener los conocimientos para poder realizar las actividades en ese lugar. Entonces, la gente siempre está buscando más oportunidades. Entonces tenemos que buscar la forma de que cuando ellos ven estas otras oportunidades de trabajo, decidan quedarse en nuestro sector, dándoles condiciones adecuadas. Y algo que nosotros hemos comenzado a hacer es simplemente apoyarlos, aunque pertenezcan o no pertenezcan a nuestro sindicato. Entonces ellos ya se sienten apoyados. Eso es algo que nosotros hacemos, que a pesar de que no pertenezcan a nuestro sindicato y todavía no estén organizados, nosotros los arropamos. We're a little behind schedule, but we're going to leave the last three questions and we go to the coffee break. We're doing great questions, but we are going to have only 3 more questions, okay? Good afternoon to everyone. Congratulations to all the panelists. Congratulations to all our panelists. And so my question is directed towards Mariana and whoever wants to answer also. This is an open question. I want to ask about the training courses that you provide for the workers. Is that specialized for a sector, for elders, for kids? And who is certifying? Who is a certifying body? And what is the level? Is that a technical level? Is it given by a university, by the state? In Dominican Republic, we have the experience that we have formal and informal care workers. We have institutionalized, those are formal, and they belong to a working group of the public sector. So, as you all have mentioned, we need them to be motivated. We need them to continue working in this sector. And part of the acknowledgement is that once that they are there, they request for an increasing wage. So for us to run those processes, it depends very much on this occupational work, and it is tied to the level of professionalization. Technical number 1, technical group number 2, and so we have this organization. It is organized like this. I would like to know if you have anything that looks alike to this, to get to know what are the opportunities for the training opportunities. And finally, I would like to know if these training hours are online, in presence, because we have a care group of the informals that even though they have a wage over the minimal national wage, they are currently working. We acknowledge that they are care workers, but they are tied to their homes. So training hours are tied to remote training. I would like to know your experience in that sense. So tomorrow we're going to have a session that is going to be just basically talking about training. He's going to deep dive. So maybe if we can just give a brief answer, don't worry, tomorrow we will have the opportunity to deep dive into this training that they're providing. So Andrew is going to be talking about this in a deeper fashion tomorrow. But currently, the care workers in Washington, they have a 70 hours training when they are going to start, and then afterwards they have to credit a number of hours of training. They have several options they can choose depending on their needs, depending on the needs of the customer as well. And there's a certification to become certified nurse assistants, behavioral health. That is something that has become really important, and through the training alliance, training partnership with which the state, the union, and the employers are working together on one hand, but also actually it is the state who set up the guidelines. This is a training. This is the guidelines for the training. If you're not unionized, you can do it through community college, or you can get certified through any other organizations. But what they need to do is that they need to set up guidelines that are set up by the state. Yolanda, and we finish over here. Solo quería agregar. Solo quiero.
After training, make sure that they have understood the competencies that are necessary for that component. And also, they go through a certification process after they've completed all this training that's directed by a different Department of Health, or they have testers in different parts of the state. Because they need to continue as a home care worker, you have to pass and be certified.
Hello, good afternoon. Congratulations to the panelists. This question is for Kelly. So, in Colombia, we are a union. We are a national union, but for public workers. Okay? We in Colombia, I think that it is 15% of the health workers who are part of us, who are part of this union. Okay? 85%, almost 90%, are in really bad conditions because they are outsourced. So when we sit down for collective bargaining, the managers they tell us that it is just for workers, that decree 160. And so we just can cover this number of workers. We cannot include the outsourced workers. And since they are outsourced, bad conditions are a common thing. And these workers are certainly not happy in general. And so we say, like, well, let's meet. We come together for a 10-15% when we offer benefits for the minimal part of the workers, and the macro part of the workers are in really bad conditions of work, when they have a high turnover because the workers, they graduate, they make their 6 months practice, 1 year practice, and they leave to the private sector where they have more guarantees, and they just comply with the requirements that are to work 6 to 1 year in the public sector. So we have a high load of work, and so they get the practice in the public sector, they go to the private, or they go to another country. So in Canada, how have you tried to go over this situation? I mean, we have always advocated as a national union. Alan knows me from a long time. We have solved several problems with these workers. We have supported them, we have helped them, but I mean, it's not what they deserve. Of course, it is not what they deserve. They were named leaders, they were named heroes during the pandemics, but the society rejected them because they knew that we were health workers, and they would discriminate us because they just didn't want us to be part of this effort against COVID-19.
So in Canada, it's different. Public sector, I got to take these out because I can hear the fella in there. In Canada, the public sector workers are the highest paid workers, and the private sector workers are the lowest. So it's opposite. And so I hear you, and I think it's bragging. I think it's bragging about what we've got in the public sector that brings the private sector to say, hey, I want that too, and I want to unionize because I want those same benefits. And it's security. Unionization is about security. Is about somebody not walking in tomorrow and saying, you know what, I'm not going to pay you your benefits. We're going to stop the benefits. We're going to stop paying you a shift premium, or you're not getting a wage increase next year. So when you're unionized, you have a contract, and I think it's a way we have to continue to sell ourselves and say, we provide stability, because that's exactly what that contract does. You sign that contract, the employer signs that contract, and by God, you're going to live by it, right? And they can't take things away from you unless they bargain it away for something else under your permission. So I think mostly it's about selling ourselves and bragging about, what we can bring to people. And I think it's job security is number one. And of course, better wages, at least fighting for better wages.
Y finalmente, María.
Mejores salarios. And finally, Maria. Finally, Maria. My question is for Mariana and for the Canada representative. So, Mariana. And first of all, we're talking about workers and care workers in health systems. Okay? So, I mean, we have gone beyond that. But another question: do those workers are not American? 100%. 90% of them are Latinos or migrants that have come from some other countries. So, the question is, your programs this is what I want to understand. I mean, are these for the attention of the American population? Because Americans have resources for private attention. So the question is, these programs and this attention through these care workers, who pays that? Who pays that? Because they are people who need to adapt to the program. to reply to I mean, you need to cover some criteria to be part of those programs. Who pay this? Is that the government? Or are these only public policies? How this works? And that is the same question for Canadian representative. I would like to understand, I mean, how is it that it works? What is the role of the government? What is the role of the society? Because I guess that there is some sort of social control related to it, because when you're talking about agencies and when you talk that the employer has control and this control goes over the union, I mean, we're talking about the private contractor who can decide for the workers. I'm sorry, this part was not completely clear to me, so I would like to get these clarifications. Okay? Thank you for... Para que la gente reciba Medicaid, no tienen que ser ciudadanos, pero sí deben de tener su residencia legal en los Estados Unidos. Entonces, sí, yo creo que esta es una falla del programa. Si hay un gran sector de la población que no está siendo atendida porque no cuenta con una residencia legal en los Estados Unidos. Y esto funciona de la misma manera con los trabajadores. Si los trabajadores de cuidados no cuentan con los permisos legales para trabajar dentro de los Estados Unidos, no pueden ser incluidos en Medicaid. Entonces, los miembros que nosotros representamos son personas, son inmigrantes, segunda generación, tercera generación de inmigrantes, y ellos sí tienen un permiso para trabajar de forma legal en los Estados Unidos. Como Katy lo mencionó, los estados tienen mucho poder al designar cualquier otro tipo de programas. Yo sé que el estado de Washington tiene un programa piloto para proporcionar servicios de cuidado personal para trabajadores indocumentados. Y además de eso, creo que, bueno, esto es también porque 775, como una representación local, lo que tratamos de hacer es... I just noticed that I am talking in English. I'm sorry. So we got,
pero también vamos a pedir,
also,
no sé, que se haga,
we request that they provide the necessary funding to pay the salaries, the wages of the workers, the Medicaid payment that we've been talking about. But we go to the Congress to request some other things. We go to the legislature in alliance, in partnership, and to support for immigration alliances or employee insurance, employment insurance for undocumented people. Even though the union does not represent those people, we are in solidarity with them. At a national level, at the international union, what we do is that we have an effort to create partnerships with groups of undocumented people who are fighting for including our programs and to make them to bring them into a national level. So of course that there is always a portion that we work for the undocumented people to be included. And so we can include immigration workers. It is true that maybe 100% of our members do have a legal permit to work in the USA. Many of their family members do not. These are complete communities, and we don't see our members just like having lives where they just care about their money and their benefits, but certainly there are policies that affect their family lives. And so we are in solidarity with them. Just to complement, It is a public finance program. It is public money. People with low income that are mainly made up of black community families, immigrant community. It is not completely, but due to the poverty that exists in the States, it is a lot. Family members, so they reflect the same communities, just to complement.
In Canada, actually,
Ok, como lo mencioné, perdón. Entonces lo que pasa en Canadá es que estamos en una crisis. En este momento no tenemos trabajadores de la salud, no tenemos doctores, nos hacen falta doctores por todos lados. Y el gobierno normalmente lo que ellos pide, todos los que quieran venir a Canadá, que tengan este grado de estudios y que quieran trabajar en el sistema de salud, son bienvenidos. Entonces se les están proporcionando casas. Lo que pasa es que tienen un contrato con el empleador y ellos revisan cuáles son los empleadores que necesitan más personal y los mandan para allá. Entonces también ellos también están cubiertos por el sindicato. También se les tiene que garantizar trabajos de tiempo completo y los viáticos necesarios para que ellos puedan vivir allá durante un par de años, y a partir de ahí se renueva. Esa es la forma en la que el gobierno lo ha estado tratando en Canadá.
Bueno, muchísimas gracias a todas las panelistas.
Well, thank you to all the panelists. I think that Ulises is going to give you your awards. Okay. And this award is for Kathy Leach. Thank you for being with us. Show it to the camera, Kathy. To the front. Okay, thank you. Kathy, this is yours. Mariana Morante. Eleanor. Andrew Diaz. So we are going to take just a small coffee break. 4:25, we shall be back at 4:25. Let's be punctual because we're missing a panel and we just want to have enough time to work it out. Thank you.
Bueno, ya vamos a comenzar con el...
Because we don't want to exceed our schedule. But yeah, we have here quite experienced experts continuing talking about caregiving. So let's start with Jorge Bermúdez, General Secretary of the Uruguayan Health Care System pertaining to the situation in your country. Thank you. Hello everyone, good afternoon. In the America healthcare system, invitation, and I want to confess, I have more questions than answers on the practice, because this is not an easy topic, and in my country, it is not easy either. But we have in Uruguay, and we are organizing service workers or companions. Hold on, Jorge. No, 1, 2, 3, 4, testing, is it working? No, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. Yeah, okay, sorry. What companionship means? It refers to workers that depend on the private sector. They charge a fee to the party that will be affiliated to them, and additionally they pay this fee and they have the benefit of the service, and it falls according to the fee, because not all quotas are the same, and it will depend on the time they have been affiliated, so the benefits will increase. So again, it's business, capitalism in capital letters. Nobody gives anything for granted, because I explain this because Uruguay, there is the idea that this is a very nice country, and our peers from Argentina are convinced to move to Uruguay, but no, it is not an easygoing country. So we are organized on the Uruguayan healthcare system of Uruguay, and it's has some advantages against other countries in Latin America. We only have one union, the PIT-CNT, the National Convention of Workers. So there is only one union. In this case, the Health Uruguayan Association organizes and represents all health workers at all the different categories: management, radiology, nurses, whatever. And the companions as well. So this allows us to have national collective groups. I brought here the Salary Council Act, where salary and working conditions are discussed. This was signed in October the 24th. It's a three-party entity, government and entrepreneurs and workers. It will be in effect for 2 years, and it covers 16 categories of the companionships, uniforms, licenses, biannual licenses, and at least 25 8-hour shifts. This is like the minimum to guarantee the salary. We would have wanted it to be guaranteed for 30 days a month, but we struggled, and this is what we got. So this is the experience for caregivers, and they are likely trained. Trained on the subject matter, and they have this task manual. It was signed in August 30, 2016. And this manual is for the companion. And for example, it starts with a definition. Companion will be the worker that devotes his attention and caregiving to a deceased, convalescent, or party, or anyone who requires companionship to facilitate, whenever it corresponds, compliance of the medical instructions according to their level of dependency. And then the tasks are described in this manual. So we have home caregivers, hospital caregivers, or companions, and nurses. There is another category for nurses that are devoted to companionship. Their salaries are in general low, like the lowest in the rate of the medical salaries, due to two situations. One, the system is very complicated, affiliation is very complicated, because being a companion, basically they are non-specialized female workers with not high educational degrees, academic degrees, and ranging the age above 40, 50 years of age. So this will be their only access to the labor market. And number two, companies are very powerful. They make big fortunes, as in the whole world, when it is about companionship. So in Uruguay, for us, it's one company, one union. And this is also ruled in the companionship service provision, but it doesn't happen in all companies, because as we all know, the best union for a company is a non-existent union, so they are systematically devoted to disassemble the incipient organizations that will conform a union. We've been listening to the different participations. We have UNI's materials, and it is clear that the active parts involve this strong sector. Let me tell you how we see it from our unionized organization. What happens with this growth in which you talk about figures and short periods of time? If this is poorly organized, this will even weaken the unionized organization, because the strong side of our union, the ones that is under continuous movement, is the administrative worker. Why? Because they can do it. Nurses are devoted to their patients, so they cannot work on this movement, and they work per shift. They don't have a monthly salary, so if they put aside this shift to work on the union, well, they lose money. If this sector grows as well as the nursing sector, our union will be weakened, because now we understand that some job positions are being eliminated due to the new technologies and the new labor world. Some are disappearing. Let's say I've been working for 37 years in medical services, and this sector is vanishing because of the electronic clinical records. Some years ago, we have to run this by manually. Same as cashiers, they are replaced by machines. This is happening in Uruguay, and this is putting at stake millions of jobs in the health sector, and particularly in the private sector. So to wrap up, we do agree with the general visions you have here shared with us. And there is this discussion between the role of the state and the role of the market. It's hard to understand, and I do have a formula. I'm not the only one. This is to suppress the state, but it's not going to happen soon. And as far as the state continues alive and we live in this capitalist society, well, there will be this situation. So the power of having these collective agreements will go shoulder to shoulder with our unions and the corporations. So, and I think I will finish with this. This is key. We do believe that the worst enemy of the union are the mere workers. When we have certain differences amongst us, we do not do what employers do. They ask. For them, it's easy. Like, how much money is there? We are 4. Let's split it in 4. But we workers, we fall in endless and unreconcilable arguments, and yeah, this prevents us within the sector, the labor sector, as caregivers or any other sector. This is like workers, we are the worst enemies for these unions. So strategically, this is key. With this, I finish. Thank you. Adriana Rosenzweig, International Counselor, and she's coming from Argentina. And she will describe the situation of caregiving in Argentina. Thank you. So before I start talking about Argentina, I want to underline what our friend from Dominican Republic stated. We've been working for many years in the affairs about caregiving, becoming visual in the field, and sometimes we say we've made enough progress, but if I grab the gender violence example, you will recall that when we incorporated this in our agenda, like it was another conventional day. We were like speaking to the moon, and nothing happened. When we started talking about caregiving during pandemic, they asked us for one day of action, and that very day, regarding different topics, made the topics appear in our agendas, and this is essential. This is very important. I think it was 2017 when we had the first ILO meeting. To the date, we've made big progress in our agendas. But it is not easy for any union having this deep level of syndicalism like the ones we have. We are all over the health sector except for physicians. It is about understanding how to organize those who do not work directly at a hospital or a laboratory. It is not easy task to change the mindset of the leaders of a union because this implies financial efforts. Neither it's easy to integrate the members of the union to involve a sector with lower salaries because they have lower training or education. So these are long-lasting processes, and grabbing the facts, we are at the point of really understanding all this, but this doesn't mean that we've made big progress. Yesterday, Sunday we are having elections in our country, tough elections, and hopefully we will win because the opponent is like a mixture of Trump and Bolsonaro, but exponentially, without structures. This person has never performed any job, and he states something that is quite dramatic for our union life. They say that our battle is a perversion because based upon meritocracy, people will make whatever they can make according to their own capabilities, not the struggle we might be fighting for the equal distribution of wealth. So this is what we are facing actually. So what happened for these last 4 years? And this president did hear unions, and this is quite critical because we were involved in the gender agenda mixed together with the labor agenda, and I embrace both of them. Like we moved forward in terms of co-responsibility, but one thing is about the agreements when we talk about maternity or other situations. One thing is that we will get more days after maternity leave and then retirement, but another completely different stuff is caregiving, provided by people submitted to hard situations, low salaries. They are not covered under the umbrella of working with other peers. So we mingle in this discussion we were talking about parental licenses. And one of the candidates that might win the election stated that same as women have the right to make an abortion, they can have the right to waive paternity, and that she will be promoting such a regulation. But this is history. They have always waived paternity. They don't need a bill. Sorry guys. It doesn't happen with all of you, but it's quite often. So now we are mingling in this, and we made no progress in labor rights. And since this is quite a niche of work, social organizations, cooperatives jump for this labor niche without experience, without training. And this is unacceptable, because those who will receive caregiving should receive this from proficient parties. And we've devoted our time and lots of resources from the Federation to gerontologist assistance. They have a level of very high level of education. They are aware of the task they will be developing, but even though all this is included in the agreement, and we signed it yesterday, caregivers under agreement 74357, caregivers will work at home stay, and nurses, for example, private hospitals determine this home stay, home caring, and agreements are overall respected. Sometimes outsourced nurses will be hired, and they are like freelancers. In general, we can cope with this. We've created an agreement for home caregivers, and different from homekeepers falls where patients don't know when they have to take their medications, they cannot go to the toilet on their own, that they perhaps are sustaining depression. No, we have proficient, trained experts with them. So we're far from having this public system that will be financing this caregiving. Let's see what happens at the elections, but this appears to be quite far in the horizon. This is our reality. Then we fall with private entities that try to adjust to the agreement, but they have their own clients, and perhaps the client will pay less and with lower quality services. State organizations habilitate residences that are so poor without real control. And seniority, elderly in Argentina, like our elders have been insulted, systematically speaking, so we have a lot of homework to do. We have run these first steps, but then there will be people working for the private sector without any collective negotiation agreements and base salaries to be respected.
We decided that we are going to have a second stage where these workers can be in the records, properly in the records, that they can have an acknowledgement and a visualization of the work they do. Of course it is a problem, but we don't want to imply that it doesn't mean that we are going to cut out cut down the wages. Because the Ministry of Labor, they are our friends. What we try to do is to bring nurses into this scheme. And these would really have an effect on the wage scale. But so, we decided we're going to work on this. This is a political decision. Of course, it is really hard to negotiate, and we know that we need to go step by step. 1 week ago, I was in a seminar that is going to happen on the next Thursday after the elections to start talking with our delegates that if the care workers are not organized, all the system will plummet. Because that's what happens. Maybe next year I will be here with you, Miguel. Maybe I will be telling you that we're going to be lucky in this process. It has been really hard. It has been really hard, but we cannot put our back on it. I mean, this is a sector in a huge growth that does not have a link with the union, that they don't have social protection. I'm sad that I'm sharing this bad news with you, but at least we're doing something. Now let's listen to Gloria Flores, President of the National Federation of the Private Health from Chile. She's going to be talking about the current situation in Chile. Do you have a presentation? Do we have Gloria's presentation? We can go to the next panelist, or you can start, either you like. I'm the president of the National Federation of the Private Health Sector in Chile. I just want to set the context for this. We are in a different situation than Uruguay. We have a union that is organized, organization that is fragmented. This is really different because what we have tried to do through the federation is to create this power, and it has been really important for us. And for that, currently we are in this work of acknowledgement, because we know that this is part of getting off the union and to break this wall, to tear down this wall where we have the union as a yellow union, just in their own company, just talking about work, talking about the collective bargaining, and without having an active participation in the real problems. So, once that we went over that stage, we tried to move forward. We also understand that it is really important to formalize and to understand who are part of our health society in Chile. Last Saturday, Gabriel Boric lobbied a law that sets the basics for a national health care system. And as I said, all the studies, of course, I mean, this is care workers, 60% of care workers are women. A big quantity of women are outside the social security system due to the work that they have, without any kind of benefit for this work. And we need to assume this topic with a gender equality scope. So, I'm just going to continue, I'm sorry. So, the care workers, of course, it is something that, well, we have a law that defines these, A care worker is defined as a person that, with a pay or without a pay, provides assistance and caring. And this is not a legal acknowledgement because they don't have any kind of social security or labor rights. I mean, even though it is stated in the law and they are recognized in the law, they don't have any of these benefits. We have a national health system that is Chile Cuida. It is a network that it is intersectorial and interinstitutional that includes all the healthcare ministries and division. But it only recognizes that it is a human right to have someone that cares for you, and it recognizes the work of the care workers. But it is not about just having a legal acknowledgement, but to protect the rights, which this law does not cover. I mean, they're talking about some health benefits that are absolutely basic. In Chile, we call an stipend that we provide to the care workers that are part of a network. And we provide 32,900. It's like $36. It is just the next stipend. And so this is just an acknowledgement. It is not a wage. And so we provide this payment for these people. So the people need to be in this record that has been meaningful because we can clearly x-ray how many people are working as care workers. This is something that we didn't have. Now it's something that we are working with a debit card that the government provides. And thanks to that, we can have these stats. Of course, we have a step forward in acknowledging the work of these people, but we can implement this plan in the next 10 years with policies that go beyond acknowledgement. We, as FENASAP, we have committed our work in partnering with our care workers through the long-term caring services for elders. But I mean, how do we deal with the people who have a formal work, who have these caring duties at their own homes? And how do we deal with informal workers? It is something that we have worked as unionists, as leaders, as organizations, together with the Ministry of Labor, Women Ministry, about how can we concile labor life and family life. This is a work that we have in process. We hope that we can strengthen this process. This process certainly includes a set of actions that we hope to be translated into an initiative to mobilize and to contribute to the formalization of the sector. As a union, internally, we have included policies in the collective bargaining that acknowledge the co-responsibility in caring about the kids. And in negotiation, we established in the Chilean law, it has been acknowledged the daycare up to 4 or 5 years that it has been established, and that it is not only a right for women, but also for the workers, for men. So we can just basically generate a co-responsibility policy in taking care of our sons. Oh well, the slides are there. So what we did on last Tuesday, what the President Boric did a week ago. So he talked about the goals, about the right, that it is a social human right. The main goal is to improve the life quality of the people. And so this is a concern of everyone. This needs to be the concern of the government, of the workers. It is of the concern of the companies, because we understand that taking care, that caring is something fundamental that sustains life. As Ruth said, since we are born until we die, we need caring. So we have set up the we have some nursing home cares for long stays for elders, and what we have done is precisely to raise awareness. Even after the struggle in Chile and the pandemic in Chile, the union has a politic role where we talk about the rights to health, the right to care, and from that perspective we acknowledge that it is important for government and for society that we do have a policy related to care workers, and that we acknowledge that they are workers. Sometimes it is not, I don't know, there are some situations where my point here is that this federation thrives policies so we can step forward to improve the life quality that we have in our society. I'm sorry, I got all merged up with this thing about the slideshow, but well, I'm just going to continue. So we need to have the visualization of the work, and we need to work in pro of formalization. We have more women working in caring positions. From FENASAP, we are promoting the debate, and this is important for several reasons. In Chile, we're currently going through a constitutional process where we are writing down a new constitution that needs to be approved on December 17, and that didn't take into account the caring right and labor as a human right. So as a unionist, I need to promote and to activate the role of the union. On top of that, in the national system implemented in Chile, it is important to mention they support the work, but they don't talk about the infrastructure. In the case of formal workers, they are not recognized, and they don't have the access to any rights as workers. We have formal workers who work in CELIAM, and they have worked for the multinationals. And like that, we can see that, they don't even have the opportunity to get to know the knowledge that are established in the country. Last but not least, I just would like to comment that as a final conclusion, I would like to say that all this formalization and the access to these rights cannot be done otherwise than supported by the union. The union, through the community, is capable, with its solidarity, it can generate the equality that we need in this society. That on an everyday basis, it's more exposed to mental health situations that require to have a companion. So we need to deal with it not only as we cannot just set up robots for this. This needs to be humanized. We need to have this relevance, and we need this caring, especially when we're talking about elders. When we notice that the society is aging, And so it is important that we notice how the economy is in risk, is going to be at risk when there is no one to take care of us. So it is vital to take care of those who take care. Thank you, Gloria. Thank you. So we go with Lidia Rodriguez Chavez, General Director of Social Wellbeing from Iztapalapa, Mexico City, when they have a really good program that is really innovative, where I think we're going to get some knowledge from. Good afternoon to everyone. Can you help me out with the slides, please? It would be great to have the slides, because you can get to see what I'm going to tell you about. So we were invited to the youth forum so we could tell you about the things that we're doing in the Iztapalapa mayorship in the public caring system. Actually, to tell you how are we doing in that sense. For those who do not live in the city, mayorships are like municipalities in the states, but the difference is that we don't have financial independence from the central government. For those who come from other parts of the world, this is what they would call prefectures in some other countries. So, from the Iztapalapa government, we have the Thrive, a caring system that is a pioneer and innovative. It is pioneer and innovative because we are creating a caring city where the state is taking care of the daily life activities that helps for those who need to be taken care of, and that acknowledge the caring worker, and that really needs to have a relationship between the public and private life. In Mexico City, since 2017, in Mexico City Constitution, we have the right, the right to care. It's acknowledged as a way of visualizing the different activities that we had up to that moment, 2017, that were considered as private and as exclusive responsibility of the families. So the right of the caring workers, the right to be taken care of, also acknowledges the presence of the care workers. Most of them are women. Maybe it is because of the culture or whatever reason it is. In most of our societies, women are the ones who take care. And so the authorities need to establish a caring system that provides public services that are in pro of those people who take care of someone without pay. All people, we all, during all of our lives, we have the need to be taken care of. The state needs to take that responsibility into their hands. It needs to be accessible, enough, and of good quality. We, in Iztapalapa, we have almost 2 million inhabitants, and we are the pioneer mayorship in implementing these caring duties as part of what we call to be a city of rights. I don't know if you know, but since 2018 up to this date, we have built 12 utopies. That's the reason I wanted to show you what these utopies are. But I can tell you that these are big places where we can come together with culture, sports, and social activities. That's what we call the utopies. These are places where we can create society. These are spaces that are managed by the prefecture, and when we offer services that are trying to decrease the load of caring duties over women. How do we do it? Our caring system have a community mess. They have popular laundries. They have a daycare. They have a daycare for elders. They have a rehabilitation, home care, and also a spa. Besides that, they have health services for women such as nutrition, general medicine, dental, and vision care. Also, we have a space that we call the challenge is to take care of. El reto es cuidar. What does it mean? Check it out. These are the spaces that we call to be the OTPs. These are kind of parks where we can find several cultural activities. All of them have pools, libraries, we have rehab homes, daycare, nursing homes, what I already mentioned to you. So these are some sort of parks where people can go. Here, this is a photograph of the spa. Here we have the rehab homes where we provide attention to people who need specialized rehabilitation. Disabled people, we have hydrotherapy, or people with learning and language problems. We also have the availability for this spa. We have the popular mess and our popular laundries. And in the mess they can only go and purchase food to take home. We have this daycare for kids. We have what we call el reto es cuidar. The challenge is to take care of. And so how we manage this? I mean, how do we visualize all this? How do we make that this public care system helps to reduce the load of duty on a woman? If a user of the UTP goes to the community laundry, they drop their clothes there. While in the meantime, the washing machine is working, they can go to the pool, to the spa to get specialized attention from a doctor, or maybe they say, no, I don't want any activities, I just want to stay here taking care of my clothes. Well, in the meantime, we also go and talk to them about empowering. The idea is to take advantage of this time while the laundry is working. I mean, instead of them being at their homes, like doing some other housekeeping in the meantime the laundry is being done. If they do have kids, we send them, we invite them to the daycare. And if the kids go to school, they get support to make their homework. If they are not at a school age, they just provide some playful activities, or they can invite them to a music class or to any sports activity. So the woman go to the laundry, they went to the doctor, kid goes back home with the homework done, they go pick up their clothes, and they go to the popular mess to get food. So we reduce the time that woman needs for housekeeping. And this is something that we are working as a government, and we are doing the job that has been stated in the constitution of this city. How does it impact in the public system? In the first place, we pay. We provide an economical support for all those people who spend time taking care of people with disabilities, people who are dependent, or elders. Up to this moment, we have offered 24 of these supports. It is not closed for women, but most of them are women. It acknowledges who takes care of the people of the care workers. We provide some scholarships for the disabled people, but who's going to take care of the caregivers or the elders? So for those people who we provide this economical support, we recognize the work that they do through customized attention service, where we have psychological services, follow up, and permanent companion. So one of the main impacts that these systems have had are to reduce the time and effort, mainly of all the activities of housekeeping done by women. And they also can use their time as a spare time or time just to rest. In Iztapalapa, never before in Iztapalapa has women been the center of these social developments. Now they don't have to think on housekeeping no more. They are not going to be under pressure for housekeeping because they can go to our utopias and they can get support for this. It redistributes in the utopias models. We have several services at ease for women, and so the state becomes the main responsible actor of taking care. So I'm going to tell you what happens in the daycare. I told you about the rehab houses, but the daycare, these are for elder people, for the elderly. So they come in and they have integral attention. They have access to geriatric attention, legal attention, psychological, dental care, and they socialize with people of their own age. Finally, what are the challenges that we have in this public system of care? In the first place, to integrate everything, because we wanted to put together some other actions that could make these models integral, such as the daycare and health services, among others. Now we have the daycare for kids, we have the health services. We tested for a mother room, but it didn't work that much. I mean, it is like a taboo in society that like lactancy is something normal. So we try to. The challenge is we try to invite men with activities that they should be done without taking into account the gender. Culturally, we've been told that women were born to take care, and that we are born with that instinct, and that men don't, and that men cannot do it. Well, as we learned of taking care, men can also learn. So in this space that we have in the public systems, that is the challenge is to take care, that space is for men, where other men teach them to raise awareness of the importance of being part of taking care. And we teach them basics. I mean, we wouldn't like to have the laundries full of women, but of men, and to change their mindset regarding so. Autonomy of the people who take care, to provide attention to the needs of the caregivers who are independent from the health framework culture, and also to provide financial support to them. Finally, the public care system is a right, not a privilege. So we need to implement this neighborhood caring system that are free for the marginalized area. We do not charge for everything, for anything. Everything is for free, but the laundry, it's 1 peso. 1 peso. So before Clara Brugada left the prefecture, she told us that we not only in the utopias we needed to implement this system. She asked us to bring it all around. Now we have 7 public systems outside the utopias. All the prefectures have their spaces, like neighborhood centers. That's where we are installing these public systems, because people do not have an utopia in their neighborhoods. So we are bringing these systems to every single corner, to every single hill in Iztapalapa.
Regarding healthcare, healthcare cannot be understood detaching it from the notion that this is inherent to women and that women know already how to take care of, but we have to modify the culture that has favored men and they do not devote time on these activities. And finally, like removing this care provision from the private institutions and make them public. So this is what we've been doing so far in Iztapalapa. We have already started with this, one more year in the government, and we will keep up moving forward. Thank you.
Muchas gracias, licenciada Lidia.
Thank you, Lydia.
El panel con Adriana Paz,
And now Adriana Paz,
Federación Internacional de Trabajadoras del Hogar, que va a hablar sobre
house workers from the Federal Association, and she will be talking about this.
Muchas gracias, Alan. Bienvenidos, bienvenidas.
Hello, Alan. Welcome. I'm not Mexican, but I live here in Mexico. We are at the end of this afternoon. We're all tired. So I will ask you some questions. Who has or has had house workers at home, full-time, part-time, 1 day a week, a couple of hours a week? Raise your hands. Please raise your hands. Yeah, me included. Who suffer when this lady somehow doesn't make it, and then you have to face doing the chores at home, and then you have to go out to the office to do your job. Women are concerned, like men don't care if she comes down or not. Everything is set. What about you? Who will cook? Who will do the laundry? Well, some of you do, some of you don't. Housework. Housework is a pillar that sustains life, sustains functionality of the society and of the whole nation. So let's start from the scratch. The International Federation of House Workers, who we are. We are like a relatively young federation, integrated as a federation only 11 years of age. 89 unions of house workers, duly affiliated in 68 different countries in 7 regions in the world: Asia, Africa, Latin America, the Caribbean, North America, Middle East, Europe. And these unions, we also have unions what is appointed as home care workers, home-based workers. But baseline is, this organization is pretty old. Our organization is 11 years old, but this base organization has been there like for 100 years. We've seen the first unions of house workers since the 30s in the Andean region and in South America. And they are devoted to formalization, acknowledgement, reconciliation, 100 years, and unions remain asking for the very same. This federation, this is who we are. Individually speaking, we are a bit more than 500,000 affiliates, but globally it's 75 million house workers in the world. Out of them, 12 million are migrants, taking part of the international migrant chains of caregivers, mainly in Europe, the US, and Canada. So perhaps it won't be strange for you that there will be workers from Filipinas, from Latin America to be like au pairs and do this type of housework in Northern America and Europe, and they are part of these migrant networks. House workers are 25% of caregivers. Globally speaking, this is a very important sector. So it's clear that house workers are caregivers. House workers it doesn't matter how they are appointed in different countries, they provide direct care of elders, children, visible or invisible disabilities, chronic diseases, and they also take the indirect care that allows us to go out every day with clean laundry, breakfast, beds made, whatever. They sustain life. We in this movement appoint that housework allows the other works to be achieved. Otherwise, either the mother or the father should remain at home to cook for their children, do the laundry, clean the house if they don't have someone that will do this. I was listening to Adriana, and she said, I do this myself. Me too, but if you have a family and you have to go out to work, this is when you struggle. If it weren't a struggle, then we wouldn't be here in gathered, we wouldn't be talking about utopias out at Iztapalapa. So house workers provide direct and indirect services. Under which conditions? Mainly on informal basis. In Latin America, informally speaking, it is not because they are part of black economy, but because the implementation of regulations about housework, and in the case of the 18 countries that ratified the 189 bill of ILO, they have not yet implemented this ratification. There is the legal structure that establishes housework on legal basis, and this is due to the work and effort of house workers organizations. However, these are not yet implemented. It is not present in the countries, like a written agreement signed by and between the employer and the house worker. They do not have social security coverage, and this is why they operate on informal basis. Chile is an exceptional country. It's not perfect, but it has the highest rate in Latin America. 54% of houseworks have celebrated an agreement, signed a contract, have social security, they have access to unemployment insurance, so they have even benefits as any other worker in any other sector. But these are the demands of the house workers' national movement that has been there for 100 years. Housework is work, and house workers are workers. This is like evident today. It's only something new. But 50 years ago they were not. It was not acknowledged. ILO until 1910 didn't acknowledge it as work, and that it should be delivered in formal and efficient ways. This is why the 189 agreement was adopted, that defines, together with the recommendation 206, establishing the formal conditions and regulations of housework. So we wouldn't be here talking about caregiving to be paid, regulated, shared. If 10 years ago we wouldn't have been talking about housework defined as work, acknowledging that housework implies caregiving. And we wouldn't be talking about caregiving to be acknowledged, regulated, understood as a decent job, and understanding the right to be cared and the right to provide this service in terms of decent and integral work. This is why houseworkers, we are sitting at any debate table talking about caregiving. National plans, because houseworkers, again, are not only the pillar providing direct and indirect care, they are unpaid workers when they take care of, when they provide care. And 98% of this population are indigenous people, black women, indigenous women, and black women. So we are talking about this intersectionality of race, gender, class. So they are fully excluded from the rights. Their salary is 50% lower than the rest of the working class. So when ILO establishes that by 2035 there will be like, let me give you the exact number. In the caregiving economy, by 2035, there will be 300 million jobs in the caregiving sector. We say, perfect, but under which conditions? Who will take care of the caregiver? Under which conditions we will establish and professionalize this job? Talking about training in the sector, we also have a high rate, perhaps the highest, of child carers. I appointed as child work.
Es un problemita con la cabina de audio. No son los micrófonos.
So where was I? Yeah, we were talking about decent working conditions for these workers and for unpaid workers, because they are in charge of providing care. And in this sector, we had a high rate of child exploitation. These workers, since they are girls, jump into this sector, start working. It's not hard to find girls that they have been like caregivers since they are 8 or 12 years of age, moving from the rural areas down to the cities to look for a job, and now they are like 50, 60 years of age and are still caregivers and houseworkers and have no diplomas or certifications. Don't tell me that someone who has been doing this throughout their lives has lack of knowledge or expertise. So we are promoting for the certification and acknowledgement of their expertise. And since there is no public regulation from the Ministry of Labor, from the Ministry of Education to professionalize houseworking, this important segment of the working class is not deemed professional. So we are looking for the certification of their competencies, acknowledging their expertise, because they have been working and doing this like for 20 or 30 years, and making it more professional, because we want quality, and professionalization is a strategy to jump out of informality or black economy, and it is a way of praising housework. It should be acknowledged with a certification and with money. Hence, they wouldn't be 50% below the working class income. I can talk about the pathway and the sheet of this route in the Q&A session. Well, thank you, Adriana. And thank you, panel members. We will have the chance to 2 questions only. Who would like to ask a question before we wrap up? So if there are no questions, let's give the floor to Adriana, because we want to hear about this route sheet. Well, we work on 4 axes to make visible housework and caregiving. This is visualization and the projection as a decent job. When we talk about community workers, I like this term, but under which conditions? Where's the projection for professionalization? Otherwise, it will be a romantic term of community workers working for free, but for their labor rights, social security, a written contract, development of their competencies. So this is where we develop the first axis. The first one. Rights. Houseworkers will not have less rights and benefits. So it's an equalization against other jobs. It's the comparison of rights. How come they earn 50% less from any other working class, and we are not covered by Social Security? Mexico just 4 years ago made this constitutional amendment to include house workers in the Social Security program to provide them with the rights. Spaces for stronger dialogues and promote the organization of these groups of house workers. Institutional spots for a dialogue, and having this collective convention with employers. The effective implementation of the law through multidimensional strategies, and here it has to deal with social security, minimum wage, according to the legislation of the country. Appraisal of the appreciation of the work, housework and caregiving, and making it professional through training and certification of their competencies, subject to these caregiving policies. And talking about the risks they face, this implies occupational health and unemployment insurance or coverage. During the pandemic, we understood the risks they were submitted to, and what is having no job and no allowances. So, Alan, we can continue talking about this. I don't know if you have questions. Well, our organization fully agree in this route sheet and quite a lot of challenges, so we have to coordinate and look how we can add up our efforts. I want to thank our panel members throughout the day, in the morning and in the afternoon. We've heard lots of challenges, but at the same time lots of progress and some route sheets. How we can guarantee that caregivers and house workers end up having formal jobs with social security, the right to organize and collectively file their claims. And let's not wait until all these workers reach the age where they need care and how we will be caring them. Tomorrow it will be about training and organization, fundamental axis for our route sheet. But to close today's session, I'm giving the floor to Norma Liliana, Director of Centista. Thank you, Ellen. My pleasure to be again with you. I was logged in the Zoom from my office. Remember that our work never ends. Now I'm heading to the traffic jam. We are working on providing Social Security to lots of workers that currently lack of it, and only when serious things happening with this hurricane in Acapulco, like the difference from an employee having Social Security, they have the chance to have a salary, they have Christmas bonus, holidays, vacation space. But those who lost everything during this tragedy, they lost everything, but they are covered, while the other percentage of the population, they lost everything. So any worker, all workers around the globe should have Social Security guaranteeing a salary and a pension. This would be basic, but it's quite a challenge for unionized parties. And now we are making visible all those caregivers, because we will need them. And perhaps in your institutions, the fact that any given patient, an elder, receives care at a hospital, this implies using a bed, a budget, multidisciplinary staff that might be might be applicable for other patients. However, there are lots of patients, unfortunately, that are merely abandoned at the hospitals, and it's quite a pity because, and they abandon them because they cannot take care of them at the given moment, at the given time, and at the same time support their household. So this is a very complicated topic, but quite relevant. And again, thank you, our peers from other countries. It's an honor having you at home. Thank you very much. And it's a pleasure having you here with us today and throughout these days. And now we will be handing these tokens of appreciation to these last members of the panel by expressing your knowledge and experience. So let's start with the first acknowledgement to Jorge Bermúdez, my friend. This diploma is for Jorge Bermúdez, Secretary General of FUS organization, as a speaker in this important forum. Thank you, Jorge. It was a pleasure seeing you again and having you here in the country. No to Adriana Rosenbaum. Our pleasure, Adriana. Gloria Flores, please, from FENASAP. Adriana Paz from House Workers International Organization. And Lidia Rodriguez Chavez from Inclusion and Welfare from the from Iztapalapa Prefecture. So then, Alan, thank you all for your attendance, and this is how we close this first day of this important forum. Thank you all. Have a nice afternoon. Be very welcome. Bye.